Hello everyone, I'm an endocrinologist working at the Department of Pediatrics and Adolescent at Samsung Medical Center, a tertiary hospital located in Seoul, Korea. I'm deeply pleased and honored to receive the Best Researcher Award from this International Research Award on PPCH. The contents of this presentation are as follows. Spectrum of pancreatic disease in pediatric and adolescent patients in a single center, and outcome after pancreatic resection due to solid pseudopapillary tumor will be presented. Pancreatic disease is a relatively rare disease in the pediatric age group. There are three etiologies of exocrine pancreatic disease in children. Those are congenital anomaly, pancreatic insufficiency, or acute or chronic pancreatitis. In the case of severe pancreatic disease, about 0.5 to 1% of cases can progress to diabetes. If you look at the etiology classification of diabetes in this table, there are type 1, type 2, and type 3 diabetes. The diagnosis of type 1 and type 2 diabetes is just as you know it. Now, if you look at the type 3C category, there is a 3C category as an exocrine pancreatic disease, according to the definition of the American Diabetes Association. To be diagnosed with the type 3C DM, a patient must have exocrine insufficiency, pathologic imaging finding, and to be negative for type 1 diabetes autoantibody. If you look at the data of other subjects, 80% of diabetic patients have type 2 diabetes, 12% for type 1, and 8% for type 3 CDM. If you look at the etiology of type 3 CDM, chronic pancreatitis is the most common at 79%, and the remaining possible etiologies as follows in this slide. As you can see below, alcohol is the most common etiology of chronic pancreatitis, and other etiologies such as hereditary pancreatitis, cystic fibrosis, hypertriglyceridemia, trauma, and autoimmune are possible. However, in children, the rate of chronic pancreatitis is lower than in adults, so the etiology of diabetes will be different from that in adults. But the data studied on this is insufficient. The purpose of this study is as follows. We want to know the spectrum and etiology of the pancreatic disease in children, which is different from that of adults. In addition, we wanted to know about the complications that occur after resection to treat solid pseudopapillary tumors, the most incident of pancreatic tumor in children, but has little research result. The subjects were 276 children and adolescents who developed pancreatic disease for 25 years from 1994 to 2019. Among these patients, only patients who follow up for at least 2 years were included, and 3 patients diagnosed with diabetes before pancreatic disease were excluded. The remaining 238 pancreatic disease spectrums consisted of 16 patients with chronic pancreatitis, 2 patients with agenesis, 81 patients undergoing surgery, and 139 patients with acute pancreatitis. There were 16 patients with transient hypoglycemia and 2 patients with diabetes after acute pancreatitis. Of the 81 patients who underwent surgery, 73 patients underwent surgery for pancreatic tumor. Among them, a study was conducted on 51 patients who underwent pancreatic resection for solid pseudopapillary tumors. This slide shows the etiology of pancreatic disorders of 276 children in a single center. Patients with acute pancreatitis were the most common at 61.6%, of which transient hypoglycemia was 10.6%, and necrotizing pancreatitis was 2.9%. In addition, 29.3% of patients underwent surgery for pancreatic tumor, trauma, or cystic, followed by chronic pancreatitis patients with 7.9%, and agenesis patients with 1.2%. Among them, solid pseudopapillary tumor, a disease of monogenic etiology in children, shows the highest frequency in 62.9% of patients who underwent pancreatic resection. Of the 238 pancreatic disease patients, the congenital disease was 6.3%, and the rest were acquired disease. Among congenital disease, pancreatic 2 single-cyst patients were the most common with 5 patients, and the rest were decidioblastosis, agenesis, pancreatic division, hereditary pancreatitis, and cystic fibrosis patients. Among the acquired disease, acute pancreatitis patients were the most common, followed by solid pseudopapillary tumor, insulinoma, chronic pancreatitis, trauma, sarcoma, Burkitt lymphoma, and pancreatoblastoma. This is the distribution data of pancreatic disease by age group. The congenital disease may be diagnosed later in childhood than expected. Decidioblastosis is a disease that is diagnosed as early as 2 to 3 months of age. Congenital diseases such as cystic fibrosis, agenesis, and pancreatic division, which may appear late, may be diagnosed in adolescent. In patients with biliary system disorders or secondary acute pancreatitis after receiving treatment for leukemia, the acquired disease was possible even in patients at an early age. Of these patients, 34% had surgery and 66% had no surgery. In the patient who underwent surgery, the solid pseudopapillary tumor was the most common. Most of the patients underwent distal pancreatectomy, which removed relatively large parts from the body and tail, followed by PPPD, subtotal pancreatectomy, and Whipple procedure. The median age of SPT patient was 14 years old, and the diagnosis period was relatively slow among all diseases of pancreatic disorder, and female patients accounted for the majority with 88.2%. 82.3% of patients had a BMI level of 25 or less, more than those with a BMI level greater than 25. When considering only pancreatic cancer patients, the most common tumor location was on the tail side, and 74.5% of the patients have tumors larger than 5 centimeters in size. As for the type of surgery, distal pancreatectomy was the most common, followed by PPPD surgery, where only the head was removed. Pathology was more likely to be accompanied by necrosis or hemorrhage, and the image findings of the pancreas at the time of diagnosis were as follows. The initial symptoms of 51 SPT patients varied. The most common symptom was abdominal pain with 60.8%, and asymptomatic patient was 27.5%. If the tumor size exceeds 5 cm, the probability of accompanying symptoms was 78.9%, and it was higher than the unaccompanied case of 53.8%. The following is the contents of the short-term outcome after pancreatic tumor resection. The hospitalization for surgery was about 13 days, and insulin was injected for about 2 days in 52.9% of patients after surgery. Postoperative pancreatitis was associated with 47.1% of patients, but only 13.7% of patients required parenteral nutrition due to delayed gastric emptying. There was no gastrointestinal fistula or wound infection. Diabetes occurred in 9 of all pancreatic disease patients, and diabetes occurred in 4 of SPT patients. Looking closely at the data, these 4 patients were diagnosed with SPT between the age of 14 and 16 and underwent surgery. All of them underwent distal pancreatectomy and were diagnosed with diabetes at 3 months to 3 years and 8 months after the surgery. Only 5 patients diagnosed with type 3C DM had a BMI of 25 or less, and the remaining 3 patients were diagnosed with type 2 diabetes. There were no complications due to diabetes in all patients. This slide shows an easy-to-read diagram reading patients who developed diabetes after diagnosis of pancreatic disease. Now, this is the discussion part. Solid pseudopapular tumors mainly occurred in women in their 20s and 30s, and in our study, the incidence rate was also higher in women than men at a 7.5 versus 1 ratio. The onset age was around 14 years old. The tumor was mainly located in the tail and was subjected to distal pancreatectomy. In most patients, abdominal pain occurred with the highest frequency among the initial symptoms at diagnosis. The tumor was mainly located in the body or tail in most patients, and 27.5% of the patients were asymptomatic. At the time of diagnosis, distant metastasis was present in 13.7% of patients. The median tumor size was 6.5 cm, and all patients are alive. Of this, the recurrence of SPT was accompanied by 2 patients, and one of the patients without distant metastasis had a recurrence. Among SPT patients, postoperative diabetes occurred in 7.8% of patients. Compared with the non-diabetic group, BMI becomes a significant risk factor when the value exceeds 25, and there was no significant difference in the type of surgery and other factors. Patients who developed diabetes after 3 years or more after surgery were patients with pancreatic atrophy, and 6 out of the group who had not yet developed diabetes have atrophy, so long-term monitoring is required. This is the conclusion slide. Pancreatic disorders are very heterogeneous in children, and diabetes incidence was 7.8% when considering only SPT patients in this study. Among these patients, unlike type 1 and 2 diabetes, 3C diabetes patients did not have a clear increase in C-peptide and did not have type 1 diabetes autoantibodies. Also, the fluctuation of blood sugar was typically severe. After a diagnosis of SPT, continuous monitoring of diabetes is necessary, and a BMI check is also necessary. So, please refer to pediatric endocrinologist. Thank you for listening.